Physicians are trained to deliver objective medical truths. However, a patient's neurology does not process language objectively during a crisis. In this moody environment, even a standard consultation can feel like a series of aggressive shocks to the nervous system, fracturing the patient's subjective reality. When the brain's threat detection system is active, clinical statements are stripped of their nuance. The amygdala intercepts the data, warping factual observations into immediate signals of psychological panic. This creates a specific form of iatrogenic trauma. It is not the result of a medical error or surgical slip, but a consequence of standard clinical syntax being delivered into a neurologically vulnerable state. Delivering raw medical facts without a linguistic filter can actively destabilize a patient's physiological and psychological baseline. Standard communication training often focuses on expressing sympathy. While well-intentioned, these emotional gestures do not halt the neurological stress response triggered by catastrophic news, such as an oncology diagnosis or a miscarriage. To address the unconscious level where this trauma is encoded, physicians require tools that map the structure of language itself. The NLP metamodel and Ericksonian indirect suggestion were developed specifically to bridge the gap between clinical intent and patient perception. These linguistic frameworks function as active medical interventions. They intercept the trauma response, allowing the physician to reframe the experience before it becomes permanently anchored in the patient's mind. In high-stakes medicine, compassion is a quantifiable, structural linguistic discipline. Dr. David B. Cheek documented this phenomenon while working with pregnant patients experiencing unexpected bleeding. These patients were routinely given a standard protective instruction: call me if the bleeding continues or gets worse. The unconscious mind ignores conditional modifiers like if. It parses bleeding gets worse as a medical expectation, an embedded command. This triggers a physiological stress response. The patient's heart rate and cortisol levels rise, further complicating their physical condition. Cheek began using an intervention that redirected the patient's focus. He concentrated the language solely on stopping the bleeding and maintaining the pregnancy. Standard medical disclaimers, intended to protect against liability, frequently function as negative physiological prophecies. Milton Erickson utilized a technique called semantic reframing to alter how a patient perceives physical distress. A physician typically asks, "How bad is the pain?" This requires the patient to neurologically search for, measure, and validate their agony. Erickson's alternative was to ask, "How comfortable are you?" This shifts the neurological mechanism. The brain is forced to search for sensations of comfort, however small, rather than sensations of distress. The physician's choice of vocabulary directs which neural pathways the patient activates. When receiving a severe diagnosis, patients often generate a surface structure in their speech, absolute statements like, "I'm going to lose everything," that are full of generalizations and deletions. The NLP metamodel challenges these verbal structures, allowing the physician to look past panicked surface structure and trace language back to the deep structure. Addressing surface panic alone doesn't resolve neurological distress. The physician must ask clarifying questions to uncover deleted information. This linguistic approach has measurable medical outcomes. In one study, hospital stays were reduced from 14 days to 12.2. This was achieved by training staff to ask metamodel questions, like, "How specifically do you know you're getting worse?" Challenging a patient's limiting linguistic model can accelerate biological healing and improve the efficiency of hospital resources. Imagine a patient calling her OB/GYN in the midst of a crisis, experiencing unexpected cramping and fearing the loss of her pregnancy. Instead of only focusing on the physical symptoms, the physician uses a metamodel intervention. They bypass the immediate panic, asking the unconscious mind to identify an emotional trigger. The doctor uses kinesthetic pacing, matching the patient's vocal tempo. As the physician speaks, the patient's breathing rhythm slows and stabilizes. The physician then leads the patient out of the trauma. They frame the next steps around the concept of getting on with the pregnancy, rather than the fear of miscarriage. By shifting the linguistic locus of control, the physician can intercept the cycle of panic and stabilize the physiological response to the crisis.
There is a significant difference between delivering cold medical facts and utilizing an NLP Ericksonian intervention. The optimized approach combines precise syntactic design with nonverbal pacing. The physician mirrors the patient's posture and uses downward inflecting vocal patterns to project calm authority. These nonverbal anchors secure the linguistic reframing, creating a state where the patient is more receptive to the physician's medical and psychological intervention. True clinical empathy is an engineered process. It requires aligning a physician's physical presence with their deliberate syntactic structure. Medical training often relies on the idea of objective truth, but this can be a dangerous fallacy. Human neurology processes the underlying structure and implication of a message, often prioritizing these cues over the raw clinical data. Mastering meta-model questions and embedded commands is an essential skill. It requires the same level of precision as any surgical procedure. A physician who understands language can protect a patient from the secondary trauma often found within the hospital system. When delivering catastrophic news, a physician's language is the first and most critical medical intervention.